Good afternoon, ladies and gentlemen. Thank you so much, Victor, for that introduction. In the interest of time, I would like to give my talk, but I want to thank you so much for coming. You are really on point. I don't know if people know that this week is the I would like to thank the previous speakers, Dr. Jacob Ilament, for educating. Here is the thing, educate. Then I want to thank the previous speaker for advocating. Now, act now. I don't know what wants to act now. So I don't know where I'm going to go. One of the three, I'll be there. So I would like to share from a pharmacological perspective, but also from common sense about some of these things. So my talk is about inclined to a solution. But before you come to a solution, you need to appreciate a few things that have happened in the past. So I would like to be pointing to where could be the remedy for the resistant pathogens. I do believe all of you, when I see majority of you are third years, so you have started chemotherapy. I would just want to add it into a real life situation, and then we'll move. I was coming and I was on Zoom and I heard Dr. Ilament emphasizing that when you talk about antimicrobial resistance, what comes into people's mind is antibiotic resistance. Yet there are many other chemotherapeutic agents, I would say, antimicrobial agents. So those who have come here, take that message. You can give one message to change and bring about a difference we need. That antimicrobial resistance is not restricted to antibiotic resistance. But what is the nature of antibiotic resistance? Actually, even you heard from the doctor, Asa, he was giving examples within antibiotic resistance. That means antibiotic resistance can act as a model to appreciate other types of resistance. But it is not entirely meaning that it is all about antibiotic resistance. So I want to just pick my information from here. For those of you who have studied chemotherapy, this is the timeline for discovery of antibiotics. 1910, 1920, 1930. Those are going to do chemotherapy, expect an objective. When was the penicillin discovered? And we always struggle with this. We expect you to be remembering Alexander what? But you forget easily. So we are here when we are talking about that. Then in 1935, when we talk about sulfonamides, you remember the first sulfonamide to be discovered around that time. So in 1940, there was too much work. A lot of discoveries, as you can see, 1940, 1960. Most of the antibiotics were discovered around that time. All of these ones you can see, the wonders we are talking about, were discovered in this time away. Then, 1970 to 2000, that's around how many years? 40, close to 30, 40 years. We say in pharmacology, scientists went to sleep. And when they went to sleep, they had created a selection pressure. As I was talking to 30 years this week, I told them the biggest driver of resistance is exposure to antibiotics. As long as we expose, these microorganisms will not allow to die. They will always say that mutate, the unfit will die, but there are those ones who will mutate. So this long period of exposure without discovering new is one of the reasons we think that gave birth to resistance. Also, we know from microbiology that some bacteria and microorganisms are naturally resistant. So when we talk about this resistance here, we are talking about acquired resistance. We can't do much to what we call natural what? Resistance, because the microorganisms is innate or intrinsically what? Resistant. What you have to do, you have to discover a drug that is not resistant to. So for acquired resistance, it is many factors, including exposure. So when you look what from here up to date, we have very few. That is the perspective I want to come from. So, when you try to classify all of these drugs, you will see this darker green, and it is indicated you are not seeing natural product. Meaning that over 80% of the antimicrobial agents have got a natural product source. A natural product can mean the plant, can mean microorganisms that don't come from the grass. Now let me talk into your ears. It can mean a rock. It can mean a fish. It can mean many things. Fungi. So natural products is a very broad thing. Are you together, sir? So I'm not meaning plants. Get my point very clear. I'm meaning natural products, including peptides and many other things. So for the interest of time, in order to understand what we need to do, we need to appreciate how different antimicrobials work. The message I want to tell you, those who are combating, is that almost all of drugs we are discovering target the following targets. The first well-known target is cell wall. So you will find that if you are to discover in many cases it is either cell wall or cell membrane. The bacteria, I had Dr. Yang saying, these bacteria communicate more frequently than us. I don't know. Actually, it was a take-home message for his people from what he said. Did you hear what he said? I'm now telling you. I said microorganisms communicate more frequently than you communicate to me. When did you ask to you? That's what I say. The point I want to make here is that when you have limited targets, that means you will have a problem. That if this group of drugs are resistant, chances are very high that even your new drug is going to be resistant. Because nobody else will have the same mechanism of action. You get it? What does it mean to us now? We need to identify and discover novel targets. And stop thinking about cell wall, protein synthesis, what's the other one? DNA. We need to think about other novel targets. That's the point I want to make in that slide. I'll leave it at that. I believe I don't have the right capacity to talk about this when Dr. Yang is there. I may make a mistake, and so I'm very afraid because this is not my area. But as a layman, I hear that the World Health Organization has classified all the bacteria into different categories. Our way of those categories, sir. You don't hear this. Some young man, I hear them. But the point I want to make is the World Health Organization, I don't know every bacteria, at least belongs somewhere, depending on the clinical importance. So we have what they call WHO critical pathogen. So as I've said, the expert is in the room. Who am I to speak about it? But get to know this classification is very important. So I leave it at that, sir. You want to answer? He's now pleading for him, don't you? Okay, so let's leave that. Ladies and gentlemen, I've left antibiotics at that point. Antimalarials. I know antimalarial resistance, some of you have not appreciated it in a way. But it is really also a big what? A big issue. And when you try to look at our common drugs you have had, quinine, chloroquine, ammoniaquine, sulfadoxine, mefloquine, arfantrin, SCTs, atobacol, and proguanil. These are some of the antimalarials. And when you try to trace, you will see that the darkness of these lines shows activities decreasing. And you will see that when you look at SCTs, I want to go to where we are. Well, by the time this data was compiled, people thought that STs were very, very effective. But I can tell you, recent information, if it is not old, that in Tororo district, there is a very high level of anti-Leucemia resistance. There are many studies in Tororo district there. And that means that there is already SCT resistance in Uganda. It is no longer news. It is everywhere. That is resistance to what? Do you know SCT, my friend? Mm-hmm. What is that SCT? What? This serious. We're gonna deal with it. Okay, so I'll leave that. But the point I want to make, ladies and gentlemen, is resistance to antimalarials. Chances are high that even what we are running to may fail to work in the shortest time to come. So I want to go through this, but I want to correlate again with this. The other one I showed you was for antibiotics. Again, when you look at this pie chart, 72% of the antimalarials have a natural product origin. What is the source of quinine? What is the source of atesune? Very good. So Jonathan wants to come and sit here. This is the representing us in the medical quiz, rather or big come and sit. We don't want you to embarrass that. When they ask you what is the source of attachment, and you can't remember to mention your what, and so you come and we talk together, such that you practice. Very good. So I'm saying that natural products, 72%, this is the literature from what I'm saying. Now, we go to the giant here, ARVs. I do believe all of you in the room have heard of ARVs, and at least you can speak about ARV what? Resistance. In 1989, I was going to ask you, when was the first ARV? What was that ARV? Very good. So in 1989 and 1987, the first ARV was discovered. And if you try to look at this timeline, you will see that Sitabai, Navikuti, Inavat, Nofovat, and Sitabai. The current talk right now is about dolutegravir, which is around 2013. There are others which are in clinical trials. But we can all see that there is already very high levels of ARV resistance. And you have to do something. You will switch, you will substitute, and time will come when people are no longer responding. I have a very contentious point. Let me repeat my position from a pharmacological point of view. If I'm given power, I will withdraw the test and treat policy. From a pharmacological point of view, public health, okay. So if I'm wearing the coat of a pharmacologist, from what I'm saying, test and treat policy is going to breed a very resistant ARV strain. And time is going to come, and I'm not prophet of doom, when the only HIV strain that is moving in our population in the 10 years to come is resistant because of the test and treat policy. That's my position, and I'm entitled to it. I'm a researcher in TB. What is XRD TB?
It is when we have resistance to both rifampicin and isoniazid, and also the fluoroquinolone.
More for this man. It's not a champion by this. So, when you try to go to a TB, which I do believe you know is a sister HIV, as they have said, there is already alarming resistance, whereby many of the patients come with MDR TB when they are actually being coming for the first time. But it can also advance to XDR TB, and from XDR TB, we also have now what they call totally resistant tuberculosis, TDR TB. And this map here is going to show you the evolution of some of those first paraminoxalic acid, rifampicin, and you will find out that from 1970 to up to date, I don't know which of these drugs is. These are just also resistant TB. Maybe the ones we are talking about is here. The dapamine, the lamivin, and the protamine. These are drugs that are now used for TB. These were discovered for other things, hope you remember. And they were repurposed just for TB after finding use. So the point I want to make, ladies and gentlemen, those who have come to listen, there have been efforts to discover drugs, but there have been loopholes here and there that have made the previous drug less effective. So I want to just highlight briefly what can be done. Working on existing drugs, there is a need to optimize therapy. And in optimizing therapy, we can look at the issue of dosing. I heard Dr. Iran also say that even your mother from Chicago can ask what? For 200 shillings. I get it. And by doing so, you are the one who's given to go and buy it. Medical doctor is going to go and buy because of poverty, definitely. You know the truth, but you can't do it, so you need to act now. You say, man, instead of buy, don't buy forever. So the issue of dosing and duration are very, very important. And this is very important that we need to optimize therapy. Then development of analogs from existing drugs. This is from a pharmacological point of view. Classic example was, for example, development of artemether from artemether. These are very, very important things that we need to appreciate. So by changing the chemical structures, we can improve some of these drug properties, including resistance profile can change in that case. I'm always an advocate of this one. I was saying the third years that Malawi and Tanzania withdrew chloroquine and they are being able to reverse chloroquine resistance. So we believe, if for example SCTs are suffering resistance, let's check if we need can work. When you stop, after in this country, you stop for 5 years, and all the resistant chloroquine strains will be wiped out. So it is possible that we can have this. But also can have resistance reversing agents. There are some drugs that have been found and they can reverse resistance in that case, as examples which are shown here. I will not talk so much about that. I would like to go to where my interest is. Let me leave this for the interest of time and go to where my interest is particularly. What is the future of microbial agents? And there is a student in Marara, PhD student, who has studied at microbial peptides. He's called Dr. Hedin. You can interest yourself and read about his work. He has identified peptides from fish scales. You know fish? Because they're not this tilapia you are eating. So, and these peptides are very, very, very efficacious when it comes to microorganisms, even those which are resistant. Therefore, currently there is a very big chain from plants to look at marine as well as those peptides. You may be interested in thinking about that. There are antibodies and biologics from those who are doing immunology. There are many of them which are being tested. Then we have this one. I think Dr. Iran is also in this position to talk about phages. I have a student who is my friend who is doing bacterial phages. For resistance, it's called Ivan. He's doing his PhD in the UK. But he conceptualized this idea from KIU and started testing the things. And these phages are really working so these are all options that we can be thinking about in that regard. So, I'm not talking about vaccines. Let me go to NaPRiC now. What have we done in this regard? So, when we come to NaPRiC, last time I presented about these 3 papers, Dr. Iran was the member of this project. They were the pioneers, and I was just hoping along the way. So there were these are 3 publications which speak exactly what is in Imbala Regional Referral Hospital and Soroti Regional Referral Hospital. And there are many other studies which have been done. So as Busitema University, this is already evidence. For example, prevalence of antibiotic-resistant bacteria among patients in Mbari and Soroti. It was very, very clear when we reviewed the documents, even when they are incomplete. But we could see very, very clear evidence that there is resistance to almost one of the first lines that are being prescribed, ceftriaxone and so on. And we went ahead to look at the prescription practices of clinicians in Mbari and Soroti. These were our study sites. And we have many gaps. And from that, I'm very clear that actually, clinicians are also contributing to what? Antimicrobial resistance. Very, very clear evidence when you read those papers and so on. So, this AMR grant round is sponsored by Bright. You heard what I'm saying? Very good. And what are we saying in Bright? We have a project that is running, and we allow me to introduce the Bright members. Maureen, Mwanga, stand up for recognition. Who is Maweje? Dr. Kanikema. Yeah. Those people are the ones who are behind this project. This project is assessing the pharmaceutical system capability and capacity to manufacture, procure, and distribute essential medicines. We have the feeling that antibiotics, antimalarials form a big component of the essential medicines. Actually, if you go to villages, these are the drugs we are looking for. Antibiotics, antimalarials, and we have added in anti-TB drugs. So this project has an objective, which I want to just flash. I will not go through this. This objective 3. We are going to assess the access and use of essential medicines, particularly those I've said, antimalarials and antibiotics. And this project, this is a pilot project where we are going to now get a bigger project. And one of the other things we want to do, want to incorporate ICT. So this objective number 4 is another where we want people like you to come and contribute. Can we do some digital thing? So we want to explore what the experiences and perceptions of communities on utilization of pharmaceutical condition systems. This is one way contributing to AMR and so forth and so forth. So we believe that we are in the right track and we can do much when it comes to that. I will not bother you a lot with this, but I will just tell you that we are in this box when we talk about AMR, access and use. We want to interview around 720 households, do this, and this is where. This is according to one health organization framework. So we shall be able to get data that is going to form a bigger interventions within. So we have around objectives. And this project is running up to 2025. And this is, as I've said already, the team behind this project. STI has come up to fund a TB project where Dr. Chimba, Mr. Chimba, Kennedy, and others are going to synthesize nanoparticles from 3 plants and test their efficacy against resistant TB. The thinking is that from a microbacterial point of view, many of the anti-TB drugs reside in the macrophages, and therefore there is less penetration of the current drugs when these drugs are in there. When these bacteria are in the what? In the macrophages. But with advent of nanotechnology, nanoparticles can increase penetration. So they are going to encapsulate already active. We have already done this. Was my plant. I think at PhD. This plant has been studied in Barara and in Makere, and there's another one which is at Mezina and again. So they are going to encapsulate these 3 products into nanoparticles and test if they can work with them here. Our target is to reduce the treatment period from 4 months to at least 2 months. That will be a very big success for us. And this is what this project is all about. When it comes to malaria, we have a math study, and this math study is looking at developing antimalarial drugs against resistant, ACT-resistant plasmodium. We have already got data done by IDRC, and it is very, very, very interesting data that our product actually is very, very effective against ACT chloroquine resistant strains. And we are going to modify it. I am the PI for that project. This discussion cannot end without talking about SARS-CoV. It will be very different. If you have not used the Tasco, I can tell you, you don't know what I'm talking about. But I would always want now in this gathering to hear who have used the Tasco. We have testimonies which are so touching that someone was treating an acute respiratory infection which had become chronic. That every month I had to take some antibiotics to make it matters worse. Right now, once they took Tasco, they have forgotten even about everything. And I'm telling you, the biggest news before this year ends is the launch of Tasco. I'm praying for you. I want right now to know what in Tasco is working. Because everybody doesn't know. It's just they are just what in Tasco is working. Before they were to put the Japanese come to take, someone was saying that they are going to buy all what you put on the market. And before you know, they are isolated and they are coming back with the same thing. We discovered. So one got so that is Tasco. And for those people who have just seen the results of the clinical trial, actually they don't believe. But for us, we had this data, we presented it for the last time. When we look at this data, we did 4 formula for Tasco. We tested for COVID-19 and other those viral infections. This is the standard. You remember? Now, remember our 1, 2, 3, 4, 5. The only one which was near Blizzard was this formula. You know what is the selectivity index? It is a measure that you will say if it is above 2, then the drug is a cut-off which we use. So all our actually what is now Tasco? Tasco is this one. But we also have this one in store. We also have this one, different. So we are saying we advance this because we are showing actually those who do consideration twice more likely to be more beneficial. It has proved it. So for us, who had this data, it was clear in place completely and also. So we are not so sure, but this is in vitro data supporting what we see. In conclusion, I'm going to invite Dr. Yamu to talk about this chart. I felt I should share. Now there is a consortium that we have been invited to participate, and it is called Antimicrobial Resistance and Natural Products in Africa Consortium. After realizing that natural products could be the solution for resistance, I'm saying could be. Then a group in South Africa led by Professor Mansati, who is our party, they have formed a coalition between South Africa, Lesotho, Botswana, Cameroon, Ghana, Uganda, Ethiopia, Tunisia, and Germany. And in Busitema University is representing this consortium. There's a discussion this week. I'm traveling, and we're going to be discussing part of it. It is going to be specifically looking at, it is in final stages, trying how the coordination will be. And it's going to be looking at natural products and AMR in Africa. And we shall be doing a lot of research how we can do natural products. I believe we can all be partners in everybody. This world, the ocean is too big for everybody to swim. So